Good morning, good afternoon, good evening, depending on where you are. My name is Dr. Robert Groysman. I am a long COVID specialist. I have been treating long COVID pretty much before it was even known as long COVID. Back in early 2020, I was performing stellate ganglion block procedures for PTSD, and it turned out that some of my patients were starting to develop long COVID, and the symptoms of long COVID, primarily is smell and taste. And eventually we realized that this was long COVID. I expanded beyond stellate ganglion procedure. Now I offer the EAT procedure, which is through the nose that stimulates the vagus nerve and cleans out the gunk in the back of your nose and throat. I've also incorporated mitochondrial protocols, gut protocols for microbiome issues and gut dysbiosis, and MCAS and excess histamine type mechanisms. I wanted to get right into the questions because they're really coming in hard. Let me first give you a quick background on why I got into long COVID. And as I said, it has been mostly from kind of falling into it from the stellate ganglion and realizing that there was something new going on that nobody else was paying attention to. So I wanted to first answer a few questions that were posted on the Facebook group from the post that I've placed there earlier. So let me do a few of those, and then we'll get on to the questions that are coming in. So the first question I have here is long COVID the same as ME, chronic fatigue syndrome, or are they different conditions? They share many similar symptoms, but they are different conditions. They share very similar mechanisms, but again, they are different conditions. One can trigger the other if you've had COVID. If you've had COVID, it can trigger a chronic fatigue-like syndrome that mimics many of the same symptoms that chronic fatigue people go through, unfortunately. Next question is, what's your opinion on the most common medication for dysautonomia, for chronic fatigue syndrome, for long COVID? There really isn't a common medication for any of these. They're multifactorial, multi-system conditions, and you need to treat the causes. And that requires first evaluating each person individually, and then deciding what mechanisms are involved, and then targeting those mechanisms. Let's see here. Question about depression and if it's connected to long COVID. Long COVID can cause depression, but depression won't cause long COVID. Long COVID can cause depression because of the dysautonomia aspect and because of the changes in the neurotransmitters in the brain. It can be treated like you treat regular depression, major depression, with antidepressants, or you can treat the dysautonomia and see if the depression resolves on its own. Okay, let me take a look and see what some of the questions we have coming in here. This question is from Morgan, and she asks, can I distinguish whether or not it was the vaccine or the COVID infection or a combination of both that started the health issues in someone? So to answer this question, the vaccine is mostly safe and it shouldn't cause problems in most people. However, saying that, there are a significant number of people reporting complications and problems that occur from the COVID vaccines, in particular the mRNA vaccines that have been linked with symptoms that are very similar to what develops in long COVID. It's difficult to know if the symptoms are coming from the COVID vaccine or the COVID infection. You obviously have to have had COVID, and some people don't know if they've had COVID or not because some infections are asymptomatic. You have a little bit of cold or a little bit of a runny nose or nothing at all. And you still could have long COVID from that, despite the fact that it was a very minor or even asymptomatic infection. Okay. Let's see. Here's a question from Sandra. Why does my pain and stiffness move around my body? Pain and stiffness come from myalgias and arthralgias. What those are pain that comes from muscle and pain that comes from joints. We know that long COVID can involve your connective tissue, can cause localized area of inflammation. So depending on the area that's currently inflamed, that's where the pain could be coming from. The second reason could be is neuropathic, and certain nerves can be irritated or injured, and that can cause pain in those areas as well. I hope that answers your question, Sandra. Hello, David. Here's David's question. I've had long COVID for a year now. Okay, that's just a statement. I'd be happy to answer any question you have about COVID, though, David. Thanks. Good morning, everyone. Good morning, Nick. Let me see here. Here's a question by Dana. How can you tell if long COVID is actually an autoimmune condition that COVID set off? Is it no longer COVID? We do form antibodies to pretty much any pathogen that enters our body that's considered foreign. However, long COVID is not really considered an autoimmune condition, and it doesn't really set off an autoimmune condition that you kind of have hidden. However, there are a few autoimmune-like conditions that occur with long COVID, such as issues with the thyroid, Hashimoto's, rheumatoid arthritis-like conditions, lupus conditions can mimic what the actual ones are with antibodies and everything else. A lot of times what I'll find is a positive ANA, which is anti-nuclear antigen or antibody, and no other markers of autoimmune disease pop up. I hope that answers your question, Dana. Nick asks a question. Why do I feel better than normal? Symptoms would be decreased after a night of fever or flu. This tells me it's likely a major autoimmune factor at play. Your immune system is going to be dysregulated by long COVID. Okay, that's something we know. The way the white blood cell counts and the way white blood cell work has been altered by COVID itself. However, it's not necessarily indicating that this is an autoimmune disease or it's autoimmune based. Many people have waxes and wanes in their symptoms based on stress levels, based on the amount their sympathetic nervous system is being pushed. That's another mechanism where you can see decreased or even disappearing of symptoms and them coming back full force the next day or in a few hours. Let me see here. This is a great question. And unfortunately, I can't post it for you guys because it's on my sheet here. But would having long COVID affect your ability to get pregnant or have a healthy baby on complicated pregnancy? The answer is yes. While long COVID does mess with your periods and it does mess with the reproductive hormones, estrogen, progesterone, and testosterone, there's no reason why you cannot have a healthy pregnancy and uncomplicated pregnancy and a healthy baby. So even though it has an ability to change the reproduction hormones, if you work with your OB, your obstetrician, they should be able to help guide you and monitor your hormone levels, and there should not be any issues with pregnancy. So I don't want you guys to worry too much about that. Let me see here. What are more typical indicators that someone is a candidate for SGBN or EAT procedure? That's a great question too. So stellate ganglion block, the way I do it is very different, as I said, than pretty much anyone else out there. And that's because my technique came about as an evolution over doing thousands and thousands of these. But a stellate ganglion block is designed to temporarily halt or stop one side of your sympathetic nervous system with communicating with your brain and the rest of your body. And what that lets the system do is kind of get out of that positive feedback loop. So what are the typical indicators? Dysautonomia. So dysautonomia leads to dysregulation of the immune system, which leads to the chronic inflammation in specific areas of your body. So anything that's caused by the dysautonomia, and that may even be MCAS and or excess histamine degranulation, because again, mast cells are part of your immune system, and even though we don't really know, and there's no real reason why these mast cells degranulate or release their contents when they do, we can obviously find triggers for that and avoid the triggers, but there's no known reason for that to happen. I believe that the dysregulation of the immune system primes your immune system for the MCAS to show its ugly face, unfortunately. So basically, fatigue, brain fog, anxiety, problems sleeping, trouble swallowing, changes in your voice, pains and aches around your body, any neuropathies, including small fiber neuropathies, are all fair game for being treated with the stellate ganglion procedure. Tinnitus has been helped by many from the stellate ganglion. It helped many. Issues with head pressure and headaches, although EAT is better for this. So let's transition on to EAT and what EAT does. And the process itself is simple, but what it does is more complicated. It actually reduces the amount of inflammatory markers in the back of your nose and throat. A lot of times it's trapped behind a layer of mucus in the back of your nose. That area, if it's bleeding, it lets that area be cleaned out because the blood washes away some of those remnants. And the actual manual rubbing is what stimulates the vagus nerve as well. So we get to stimulate the vagus nerve in a way that you can't do outside your body. So a lot of things that involve the throat, swallowing, your head, especially head pressure and pressure headaches that don't seem to resolve with anything else, seem to do really well with EAT. Constant runny nose, postnasal drip, sore throat, all those tend to respond really well as dysautonomia that we see generalized throughout the body. Those are the main indicators for those procedures. So here's a question from Mike. What is the best treatment for brain fog and dizziness? Well, the best treatment is to find the cause or causes. Brain fog can be caused by dysautonomia. Brain fog can be caused by having histamine dysregulation. Brain fog can be caused by mitochondrial problem or dysfunction. Dizziness tends to be caused by POTS. Unless we're talking about vertigo or feeling like the room is spinning versus you spinning. So they have kind of different, slightly different causes. But really, if I think it's being caused by dysautonomia and the other symptoms match, I may look at the heart rate variability. I may look at the resting heart rate. I may order a autonomic nervous system test if I'm not sure. I may email my patient a lean test to see if they can do it at home instead of going to their neurologist or cardiologist for a tilt test, which are brutal. But my point is once I've identified the cause, I would treat the cause. And really the main treatments for dysautonomia would be the Stellate Ganglion Block procedure, the EAT procedure, and one or two supplements could be helpful. If you want to just treat the symptoms of POTS, and POTS can certainly cause brain fog and dizziness from in its own right. It really involves two things. One is lowering the heart rate, and the other is increasing your blood pressure. However you go about those two things, that treats temporarily the symptoms of POTS. I hope that answers your question. Let's see here. I'm going to go back to the beginning here to make sure I didn't miss anybody. And some questions I can't answer. I will be able to answer most of them. Yes, I knew this was going to come up. Yes, David, hi. Do I recommend ivermectin? I do not recommend ivermectin. I don't think it really has a place in long COVID. Honestly, I don't really even think it has a place in COVID anymore. In the beginning, when we really had nothing and we were grasping straws, people were trying many different medications that were around a long time, like hydroxychloroquine, like ivermectin, like colchicine. And I realized that this is still part of the FLCCC protocol, but I am no longer part of that, and I do not subscribe or recommend ivermectin for long COVID. I hope that helps. Rhino Joe asks, is there any link between endurance athletes and long COVID? Well, first off, let's say that there's not. It doesn't really matter if you're in great shape or not, but it does matter if you have coexisting or pre-existing comorbidities. What that means is if you have heart disease, if you have kidney disease, if you have liver disease, if you're 3-pack a day smoker, that's going to affect what happens post-COVID. But being an endurance athlete actually puts you in better shape. Your mitochondria are likely in a lot better condition than somebody who's a couch potato. Being in deep training when you got COVID, if we're talking about post-exertional malaise, which is a common symptom that we see post-COVID during long COVID, as well as exercise intolerance, a lot of times occurs due to mitochondrial dysfunction. So let's look at it this way. COVID comes in, it comes in through your respiratory tract most often, and some of the viral particles will infect other organs because that's just what happens. And depending on where it infects, it could potentially damage those mitochondria directly. That is, the mitochondrial DNA will be altered so that the mitochondria doesn't really work the way it's supposed to. And if you do that enough in certain organs, it will lead to shortness of breath or problems with endurance. Okay, this is treatable. And a lot of what we learned about mitochondrial dysfunction comes from primary mitochondrial disorders that we see in kids. Now, all mitochondria come from the mom's egg. None come from the sperm. And basically all the mitochondria we have in our body are duplicates of the original set that we got because we can't manufacture a brand new mitochondria from scratch. So what that means is that some of these kids, if they've inherited mitochondria with some kind of problem from a mutation or something else, these mitochondria don't work, but they don't just not work in one organ, they don't work in any of the organs. And a lot of what we learned is from kids who are suffering from these primary mitochondrial disorders. Long COVID is a secondary mitochondrial disorder. That means that it's acquired, number one. And number two, it's not involving every single cell in your body in every single organ. Okay. So that's why it's a lot more amenable to treatment than primary conditions are. Doc Cat asks about suggestions for getting healthcare providers to listen and to take, I'm assuming I could be wrong, I apologize, instead of telling me it's just depression and anxiety. So one of the things that I've done is I've published these books. These are as much for healthcare providers as they are for patients. They're just technical enough to make it useful for healthcare providers, and they're also easy to understand for patients. But here's the second edition. Okay, this is the new one out. This one's called the Complete Long COVID Handbook. It's about 100 pages larger than the first edition. I've included a lot more information about it than I did in the first edition. You can also show them this, which is the Complete Long COVID Handbook, the Dysautonomia. Now, I'm still working on Volume 3, which will be the mitochondrial dysfunction, and Volume 4, which will be the gut dysbiosis, and Volume 5, which will be the MCAS histamine axis. I also made this for children or really young adults or people with a lot of brain fog who cannot, I guess, digest some of the material in the original Volume 1. But that's one way, is through knowledge, is education. I mean, you would think that somebody who went into medicine would be open to learning new things, learning about things that they don't understand or haven't learned yet. We have to do that anyway every year. These are called CME credits, or continuing medical education. So it's not out of the realm for a doctor or a healthcare provider to learn new things. And it's okay to say, I don't know. That's not my thing. I'll send you to somebody who does know this thing. Some of them will actually take you seriously and will help. But this is not depression and anxiety. This is not all in your head. This is not psychosomatic. There are millions and millions of people suffering with long COVID. It's a real condition. You are not crazy. It's not all in your head, okay? Julie asks, what helps with severe gastritis? So gastritis would be treated very similar to how it is treated from non-COVID or non-long COVID caused gastritis. So there isn't a lot of new things that need to be introduced. However, you can look at histamine levels, because excess histamine will cause excess acid production in your stomach, and that could lead to gastritis. Okay? And if there is a vagus nerve dysfunction, there is also potential dysregulation of when acid and the enzymes that are normally secreted by your pancreas and from the bile in your gallbladder are introduced into the digestive system. Okay? Now let me look at my list here. The question I have is, what do you think causes the body vibrations and what treatments work best for them? So the best way I can explain body vibrations, and these would be internal, so you would not be able to see this or anything be visible when somebody's looking at you. You wouldn't see any shaking or anything else. It's kind of a neuropathic sensation that a lot of people with long COVID tend to have. It tends to be often in the chest area or the center of the chest, sometimes in the back or other areas. But these to me are neuropathic sensations that you're feeling from irritation or injury to one or more of the nerves. And I treat these primarily with treating dysautonomia. Okay? Another question is, should we try to get better or deal with certain aspects of our long COVID before doing an SGB? Or can an SGB be done right away? Or does the order matter at all? The earlier you do the stellate ganglion procedure, the better. And here's why. Your nervous system is designed to adapt. And having a dysautonomia, especially one where there's sympathetic overdrive, where you're in fight flight 24/7 or close to it, your body eventually will accept that as the norm. And it's going to be much more difficult to get you out of that fight flight situation. So if you're having lots of anxiety, if you're having issues with insomnia or unrefreshed sleep, if you're having the brain fog and the fatigue, do the procedure earlier rather than later. The chances of recovery are much higher if you do it earlier. All right, let's see what we got here. I am looking through. So here's a question by Burtis. Had 14 months of inferior turbinate swelling, first COVID infection, and resolved after 14 months. Now 5 months into reinfection and same issue. Any medications like acyclovir, it's miserable. So again, just like everything else, you want to determine the cause of your swelling. What is going on? Is it new allergies? Do you have some kind of chronic infection going on or sinusitis? So acyclovir is really meant only for Epstein-Barr virus or mononucleosis or any of the herpes family viruses such as chickenpox or varicella zoster. There's several others like CMV and several herpes simplex 1 and 2 and several others that are not as well known. But acyclovir is really meant for those conditions, and the way it shows up is with little vesicles that are infectious, but I can't obviously tell you if you have that or not, but that's not a typical area where herpes would infect typically. So yes, there's a way to manage it, but you need to figure out first why your turbinate is swelling in the first place. So I'm going to review and see. I won't address anything about cost of procedure or anything that's specific to treating you specifically because I don't know you. I need to examine you. I need to talk to you. And we need to review medications and we need to review supplements and we need to do and order some lab work and review that. So I wanted to just kind of reiterate that nothing I can really say here would be considered medical advice for you because I can't take you on as a patient from a chat group or Facebook. So here's a question about nicotine patches from Brian. How often can you safely do this and how much time should I wait each time? So I still use nicotine patches occasionally. However, you should know that the original study that was done was not placebo-controlled, not blinded. It involved 4 patients. And while all of them benefited from the nicotine patch over the course of 30 days, because there is risk to the endothelium, the vascular endothelium, that's the lining on the inside of your blood vessels, nicotine has a potential of injuring that and resulting in atherosclerosis. We don't really know how long you need to use nicotine for that to happen. However, the least duration is the one that I would recommend. I typically recommend under 30 days or 2 weeks, whichever is more helpful. Here's the thing, though: if you're putting a patch on and it helps, and then you take the patch off and the symptoms come back, what exactly have you helped? So, could we do the same thing with something less dangerous? Is the question. If you get several weeks of relief, if you get several months of relief after nicotine patches, I'd be more likely to recommend them. Julie asks a question: does a positive EBV early antigen IgG titer after COVID mean anything? Yes. So there are 4 things we check for Epstein-Barr reactivation. First off, obviously, you have to have had Epstein-Barr or mono. A lot of us have. It's a very common infection that we get as kids or as teenagers. It's called the kissing disease. It's called mononucleosis or mono. And early antigen basically tells you if the Epstein-Barr is reactivated or not. It doesn't tell you if it's causing a problem. All it tells you is that it's reactivated. Now, something like chickenpox, if you have the zoster reactivation, you usually know that it's reactivated because you get a stripe of vesicles or little bumps with fluid in it along a nerve root or dermatome, and a lot of pain or itching. With Epstein-Barr, you often don't know. It can present the same way as mono, which is the swollen glands under your chin, and basically cough-like or flu-like symptoms or cold-like symptoms. So it is considered a biomarker, even though it's not official, and it won't relate to COVID or long COVID directly, but a reactivation of latent viruses is something we see during COVID and even during long COVID. Can I recommend any clinics or specialists to treat long COVID damage to the brainstem? That's a question from Toby. My question is was this spontaneous brain bleeds, or are you on triple anticoagulant or triple, anticoagulant therapy, or are you on any anticoagulants that would explain why you're bleeding? That would be my question to you, Toby. Mike says that I stated that you can't flush spike protein from your body. Why? Because you can't. You can't remove a protein from the body. Now, certain types of plasmapheresis can specifically remove certain autoantibodies, for instance. And there is the HELP apheresis, which technically removes fibrinogen, okay, not microclots, not anything else, fibrinogen from your body. But there really isn't a way to filter spike protein, and taking anything orally or IV or topical is going to remove a protein from your body, spike protein or otherwise, okay? That's just a misnomer of how your body works. Now, I know some people are, making some money off this by making certain claims, but I'm telling you, you can't really remove a specific protein like this from your body by taking something orally, okay? C Trader asks, where do you recommend we buy peptides to fix the gut? Well, there's an official answer and an unofficial answer. Many of the peptides in the USA have been effectively banned. The FDA reclassified peptides back in November of 2023, and it reclassified them as essentially medications. So when the FDA approves a medication, you have to have studies done, not the FDA, but you, that is the company that makes them or manufactures them, the medications, that shows not only efficacy, but also safety. Now, these peptides are not really patented or trademarked in any way. Any pharmacy can make them. So the issue is who would spend money on doing research on these peptides that have not been tested for safety or efficacy for the most part. I mean, yes, we have the historical safety for them, but maybe not the efficacy completely. So the main issue is that nobody's going to spend money on these studies when they can't profit off them because they can't really patent or isolate this peptide now and say this is mine. Any company can technically make this, and you probably have seen the controversy with semaglutide, where a lot of compound pharmacies were making their own versions, where the two main companies that make it sued them because saying, hey, we have a patent on this, we developed this system. And they say, well, it's a peptide, it's a collection of amino acids, you can't really patent that. It's a piece of protein. So it creates a lot of problems. So to answer your question is officially it's very difficult to get peptides in the USA. Some labs get around this or some pharmaceutical I guess companies get around this by putting for research use only. There's a little bit more leeway to a 501B pharmacy versus a 501A. So let me say you have to be creative, okay? That's all I can say officially on a public channel like this. Here's another question from Michelle. Do your treatments address post-exertional malaise and fatigue, particularly from cognitive exertion? So let's define what post-exertional malaise is. Okay, so that is feeling pretty lousy, but not immediately after the exertion. And the exertion can be both physical or mental. So if you're taking a hard test or you're computing something or using your brain versus you running a marathon type thing, from post-exertional malaise standpoint, it's about the same. So we don't know the exact cause, but there's been significant progress made to determine that it would be either from mitochondrial dysfunction, okay, or dysautonomia that causes this. And you have to treat the cause, which means you have to determine if it's one, the other, or both. Occasionally it is both. Now, the fatigue and cognitive decline, such as brain fog, those can occur from several different causes. But post-exertional malaise tends to be more often than not to be mitochondrial dysfunction, okay? And yes, I do treat post-exertional malaise. It's not an immediate fix, which means it's going to take several weeks to work on, okay? And by the way, do not try to push through. Graded exercise is probably the worst thing you can do for post-exertional malaise. You cannot force your body to do more and then crash. You're going to cause more damage and more problems doing it that way, okay? There's been a few studies showing that. David asks, anyone get an adrenaline rush at night, all of a sudden have more energy? So sleep is disrupted due to fight flight. And while you're in fight flight, your body will not be able to really go into deep sleep. Now, you may not even be able to go into light sleep, We have different stages of sleep that we go through every night, several times. Everything from being slightly awake to light sleep to deep sleep to even deeper sleep. So stage 3 and 4. And if your body is stuck in fight flight, you are producing adrenaline because that's what your adrenal glands do in response to increased sympathetic activity. So this adrenaline or epinephrine and norepinephrine are released, not just at night, but throughout the day. There's different triggers. And when you do that, your body will also try to compensate by releasing cortisol, which is a corticosteroid that's also released by your adrenal gland, and that's designed to quiet the system down. Cortisol tends to make you more wired too. Okay? Here's a question by Jayesh. Is it possible to cure COVID-induced anhedonia? So anhedonia is part of the cognitive syndrome that we see with long COVID. Sometimes it's anhedonia, sometimes it's depersonalization, sometimes it's derealization, sometimes it's depression or anxiety. They all fall under the same umbrella. There's a neurotransmitter disruption that occurs due to long COVID, whether it's due to blood flow or due to inflammation, we don't quite know. But a lot of these symptoms tend to reduce or reverse once you treat the dysautonomia. Okay? Hetty is asking, how often do I see people fully recover? Actually, quite often. It's actually quite surprising that I see this as often as I do. But the reason that I see people fully recover is because I'm targeting the causes, okay? I'm not just chasing symptoms. I don't just put people on a bucket of supplements and medications just to kind of try it out, see what happens. There was some LDN in there, put in a little Mestinon, put them on vitamin C and midodrine and see what happens. No, I have a very systematic approach to this, okay? And I've seen a lot of patients do 90% or better post-treatment. It's not going to be an immediate cure. It's not going to be an immediate turnaround. I don't even use the word cure, okay? I use treatment. Not cure, okay? Hi, Brandy. I've addressed the internal tremors earlier in this podcast. The small fiber neuropathy, again, would be very common in people with long COVID. I believe this to be a dysautonomia-induced syndrome. There are a few people who have had success with IVIG in the treatment of small fiber neuropathy. But what I would first do is test to see if you have an autoimmune component on top of the small fiber neuropathy. And that's when treating the small fiber neuropathy with the IVIG makes sense. Otherwise, I treat it with the Stellate Ganglion procedure and vagus nerve stimulation. Okay? Would an SGB possibly help with non-epileptic autonomic seizures? I'd need more information to be able to answer that question for you. I'm not sure what you mean by autonomic seizures. All right, let me go back to my list here. I'd like to ask if I can talk about EDS or hypermobility spectrum disorder being a factor in developing LC or long COVID, especially with regards to fatigue, joint muscle, and nerve pain and brain fog. Yes, EDS, Ehlers-Danlos Syndrome, or hypermobility spectrum disorder is a genetic condition where there's a mutation in one of the proteins, and it causes the connective tissue to be more stretchy. It also has effects on nerves and joints as well, and skin. And yes, EDS and hypermobility spectrum disorders do increase your risk and is a factor in developing long COVID. And the main reason is because from everything I've learned so far over the last 5 years is that anything that has a pre-existing injury to your autonomic nervous system can put you at risk for long COVID. And that includes EDS and hypermobility disorder. That includes Lyme disease and many other prior infections and prior conditions can also put you at risk. Okay? Let me take a look back here. Jay asks, have you found that stellate ganglion block and therapy helped people with dysautonomia that came on before COVID, but was worsened by COVID? So those treatments are not specific to long COVID. They're more specific to dysautonomia. And whatever caused the dysautonomia in the first place would be helped by these treatments. Now, typically, if you go out there and look for a clinic, whether it's a dysautonomia clinic or a long COVID clinic, what you're going to find is a POTS clinic. Okay, so what they do is they treat POTS, and I already explained how POTS is treated. It's symptomatic. You decrease the heart rate, so you prevent the palpitations and the tachycardia, and you increase the blood pressure to lessen the impact on the heart, so you don't get dizzy or pass out. So those are the two main ways that dysautonomia and POTS are typically managed, but they don't really treat the original problem. It's a Band-Aid. They treat the symptoms of POTS, which is okay. I mean, it's a perfectly fine way. I mean, that's how you treat high blood pressure, right? You take a pill once, twice, 3 times a day, and your blood pressure comes down. You don't have to even know or care about what causes your blood pressure to increase, as long as taking the pill lowers your blood pressure. That's how you can manage POTS. And in some cases, it's dysautonomia. But as soon as you stop the treatment or stop the therapy, the symptoms will come back. Question from C-Trader 09 asks, for those with gut dysbiosis and neurovascular dysregulation and POTS, does modifying diet help with healing, or does it make a difference? So one of the major mechanisms in long COVID is gut dysbiosis. That's because COVID can directly damage and injure the microbiome. It's a delicate live system of bacteria, viruses, fungi, yeasts in our gut, mainly the large intestine, that helps regulate a lot of the processes in our body, including our brain, our heart, our lungs, our liver, and our kidneys. These are called axes. There's the brain gut axis, there's the heart gut axis, and so forth. So whether or not every single person has gut dysbiosis, it's not likely. Some people do, some people don't. Now, the gut can control the brain and other areas by releasing different neurotransmitters, not just by itself, but also from this microbiome. And it can communicate through the vagus nerve. So yes, diet does matter. And diet can help with healing. Of course, if you have a hot dog and nacho chip diet, you're not going to do too well. But and I know it's Super Bowl Sunday, so hot dogs are allowed today. It's official, and the point is to reduce or reverse any leakiness in the gut, the leaky gut syndrome, to see if there's any SIBO that develops in the small bowel. Basically, the microbiome growing out of control in the small bowel when it really should be limited mostly to the large bowel. And improving absorption, that's probably the most important. Some nutrients and essential minerals and vitamins are not well absorbed if the microbiome is disrupted. I'm assuming, Toby, you mean what EAT stands for? And it stands for epipharyngeal abrasive therapy. And I think you already spelled it, so it's good. Flavius is asking if an SGB would be recommended for dysautonomia with orthostatic hypotension, with POTS, with postnasal drip and acid reflux. The answer is I don't know. I need to evaluate each person individually. That means that we review your history, we review all your symptoms, we review what you've been on, we review any labs that you've done, and kind of determine to see what the next step would be. So it's possible, but it needs to be done in a one-on-one session. Can a TENS machine help with HRV and general dysautonomia? Question asked by Karen. That's a great question. And yes, it can, but not the TENS machine itself. It's the vagus stimulation that does the work. So when you're stimulating at the ear, you're really mostly stimulating the connection or the communication between the ear and the brain. So it goes into the brainstem and then goes into the brain. And that's where you get the improvement of the cognitive symptoms. And indirectly, now the brain sends down the signal down the vagus nerve that affects your heart and affects your lungs and affects your other organs. So it's a slow and steady type mechanism. So you're looking at a minimum of 3 months. Some people need much longer. Some people need 6 months. It's an everyday or at least 6 days a week stimulation for at least 30 minutes. If you're stimulating at the neck, you obviously can't stimulate for 30 minutes. You can't stimulate for 15 minutes either. The stimulation would be under 5 minutes typically because of the side effects that occur from stimulating the vagus nerve at the neck. Do you know where your vagus nerve is in the neck? So that's kind of an important thing. It's not just put the device on your neck and hope for the best and press the on button. You kind of need to know where the nerve is, okay? The ear ones tend to be more gentle, tend to be better tolerated, and provide the longer term stimulation that is needed to get the vagus nerve to do what it needs to do. So if you're stuck in fight flight, your vagus nerve is probably under functioning, okay? And stimulating it for 5 minutes is not going to do a whole lot for your general well-being and healing. So the point isn't to improve the HRV. The point is to improve you through healing by stimulating the vagus nerve. And the HRV will improve because you're healing and you're feeling better, not because you're actually acting on the HRV itself. Okay? Nomad asks if ibuprofen affects the parasympathetic or sympathetic nervous system. Talks about his girlfriend trying it for the first time and said all her symptoms went away in 5 years. So ibuprofen is a non-steroidal anti-inflammatory drug. That's what it is. It works on a particular part of the inflammatory pathway involving arachidonic acid. It typically is not as strong, for instance, as a steroid, which hits multiple different pathways. Ibuprofen or any non-steroidal um, non-steroidal anti-inflammatory drug would work by this mechanism. I can't tell you why she felt better, except it decreases inflammation, not just um, for pain. It would decrease. It's a mild anti-inflammatory, so it would decrease inflammation in certain parts of the body. Okay, I can't tell you why she felt better, but it's not parasympathetic or sympathetic related. Here's a question from Ken. Good morning. Um, are there any updates on loss of smell from COVID or any cure to get smell back? So in the first few years, when COVID was a pandemic, we saw many patients with post-COVID have developed both loss of taste, loss of smell, or abnormal taste or smell. The ones that are developing long COVID now from the Omicron don't seem to be having much smell or taste issues. So there's no real research or studies being done that I'm aware of. However, what I have seen is that there are several mechanisms to recover. The earlier you attempt the treatments, the better, and have a much greater chance of recovery. But if it's been too long, it is possible that this may be permanent. I'm sorry to say this, but in some people, it will not come back. However, if you're interested in trying something for it, a stellate ganglion procedure is probably the most effective, followed by vagus nerve stimulation, nicotine patches, and again, the nicotine patch is really just a four-person study. I wouldn't really put a lot of stock in there, but it's still a possibility. And you have a couple of nasal sprays that have been. There's been one study for each of these. There's one for theophylline. There's one for insulin. There's one for vasopressin or it's oxytocin is the one I was thinking of. That has been shown to help with smell and taste. At least one study. So there's also something with stem cell or PRP injected at the top portion of the turbinate or the septum that has been shown to be helpful. The study is a little iffy, but there's still potential there. If you're interested in any of these, just give my office a call, okay? This will be our last question since we're coming up to, well, actually, yeah, we're coming up to an hour here. If this is a question from Morgan. So if we started having symptoms 2 years ago and we didn't know about you or what was causing our problems, we don't have a chance of getting better with SGB. I was diagnosed with POTS January 24. No, that's not what I'm saying. All I'm saying is that the earlier you treat the dysautonomia, the better the recovery or success rates are. It doesn't mean that you can't. What I found from my own experience is 3.5 years tends to be a turning point for this autonomy. It doesn't mean that it won't work after 3.5 years. It just, the success rates are lower, okay? But my advice to you, Morgan, is to get it done and get it done as quickly as you can, because really diagnosing and treating these early is what leads to the high success rates that we're seeing, okay? All right, guys, thank you so much for joining me. I'm sorry I couldn't get to all your questions. I will do my best to try to do another one of these next month. And my plan actually is to do the last Sunday of every month. That's my plan. And I want to, I guess, pick a better time for you guys. I know there's some people from the other side of the pond that have trouble participating or joining in, which is unfortunate. Remember, I'm doing these. I'm taking time away from my family, and I'm kind of driving into the office to do these for you guys, and I'm happy to do it. but it's hard for me to do these at night because I don't know if you guys know or not, but I'm also a long COVID sufferer, and I've been dealing with this for a long time. I've gotten most of my symptoms under fairly good control, but long COVID is long COVID, and I've had COVID twice, and I've been vaccinated 4 times, so it does take a toll on you. So again, a lot of the things that I talk about are in my books, okay, and I have several of these. I'm going to show you one last time before leaving. Um, the Complete Long COVID Handbook, Volume 1, second edition. And this is Volume 2, which is the Complete Long COVID Handbook, Dysautonomia, which really just looks at the dysautonomia parts. I'm still working on Volume 3, 4, and 5. Those will be mitochondrial dysfunction, gut dysbiosis, and MCAS or histamine excess. And I've written one just because some people were saying that they were having a hard time understanding it. So I've actually simplified a lot of the stuff in the Easy Long COVID Handbook. It's basically the same information as in here, as the second edition, but it's more simplified. It's easier to read, and it's even good for teens and younger kids. It's really written at the 5th grade level. Okay, thank you so much for coming to join me today, and I will try to get to all the questions next time. Okay, I know there's a lot of questions, and it's really hard for me to go much longer than an hour without a partner. So if anybody's out there and they either have some social media presence and have an interest in long COVID, wanting to join me as a partner on one of these talks, it's kind of more fun to have banter between two people, but I couldn't find anybody this time around. So if anybody's out there, you can contact me through Haley or through one of my groups and let me know. Okay, thanks a lot and have a good one.